Hi, everybody. Welcome back to another live episode of RetFix and Chill here in Chicago. We're going to be talking about scleral buckles today. So this is a topic that's near and dear to my heart. It's a surgery that I didn't feel super comfortable with coming out of fellowship. And I had the great pleasure of learning from my colleagues at the Young Retina Forum, which is a Telegram-based messaging platform where I asked all these people with a lot more experience than me how to get better at scleral buckles. And it was a great resource. And one of the founders of the Young Retina Forum is here with us today, Mitul Mehta. He is a clinical associate professor at UCI at the Gavin Herbert Eye Institute. He's also the wellness czar. I've learned a lot from him over the last few years and look forward to learning a lot from him today. Mitul Mehta, thank you for joining us, and I'm looking forward to learn from you.
Thank you for having me. You know, we started our association as the Young Retina Forum, but then my hair became really white, so I had to change the name of it to the American Retina Forum. So now we're part of the American Retina Forum because I'm not young anymore. But I'm going to talk about something that's near and dear to my heart, scleral buckles. When I came to UCI, no one was really doing scleral buckles, and I started doing them, and the chairman started calling me old school because it's an old technique. People were doing them in the 1940s, but they're still an amazing surgery, and everyone should learn how to do them, especially for younger patients. So I'm going to kind of go over some tips and tricks, how to get comfortable with some of the more advanced techniques in scleral buckling, as well as figuring out what it is to make you get started with scleral buckles. All right. And here are my disclosures. The rules of retinal detachment repair are very simple. There are only 3 rules. You need to find the breaks, treat the breaks, and close the breaks. If you do those 3 things, your retina will reattach itself if it's due to a break in the retina. And so here's an example of a case I did. So Dr. Zahid, you see the breaks are all along the superior edge of this bullous detachment and it's affecting the macula. What would you do for this macula off retinal detachment? And there's a young patient, 40 years old.
And the hyaloid's on.
The hyaloid's down.
In this case, this is a great scleral buckle case. In all honesty, back in the day, I would only buckle this patient, but I've started doing more pneumatics for younger patients, but that's a topic for a different day. But this is a great candidate for a encircling or segmental scleral buckle. But what I would want to know from you is it's fairly bullous, so you'd need to get drainage, and I'd worry about apposition of the buccal crest to the breaks. So I would have a low threshold if I'm not able to drain to add a small SF6 bubble to help reoppose the retina to the buckle. I would probably do an encircling band here because it reliably works well in my hands, especially with these hyaloid-on younger patients.
Exactly right. So this is how scleral buckles with encircling bands work. You put the band around the eye and you close the break from the outside of the eye. The advantage of having an encircling band is it's treating stuff that hasn't broken yet. But that doesn't mean it won't break in the future. You saw this patient had 3 clock hours of lattice degeneration in the area of detachment. What you didn't see was that there's also inferior lattice in the same patient. And so you want to prevent the detachment in the future. So by putting the band around the eye, you're decreasing the circumference of the eye and closing the break as well as supporting the retina where the vitreous hasn't pulled off yet. So this patient could develop another break and another detachment in the future. And the reason scleral buckles works, and this is from the Michael's book, Principles of Retinal Reattachment Surgery, you can see where the breaks are. So in this case, the break is superior and is causing subretinal fluid to go inside the break and underneath the retina. By putting a scleral buckle on, you're closing the break from the outside and pushing the fluid away from the break. So then the RPE does its job of pumping out the fluid. This is why some people don't drain buckles at all. They'll just put a higher buckle to make sure the break is closed. I like to drain because I like to get the fluid out. Because this is an example of why a scleral buckle wouldn't work. Because if the fluid is very loculated and you're just pushing the sclera from the outside, you're just pushing the fluid towards the break and it doesn't displace away from the break. So it's not actually going to close the break. So it doesn't matter if you put any sort of treatment on, it's not going to close unless you do something like you were mentioned earlier, put it in a gas bubble, and a gas bubble would help close the break from the inside as well as the outside. And so one of the things that people don't realize is during a scleral buckle, you don't actually have to completely close the break during the buckle. You just need the retina to be closer. Because the retina is closer, and with the natural movement of the eye, you're changing the vector forces of the fluid. And when the fluid vector forces are not going into the break, but rather they're going out of the break, what ends up happening is that the RPE gets closer and closer and closer to the retina until it becomes appositional, and then your pexy starts to scar it. Or you can add laser later on. And so that's how it works. Now, this is the chart that Myra gives when they give you scleral buccal components. A lot of companies do sell these components, but this can be very intimidating to a lot of people. There's so many choices. But the reason there's so many choices was because in the 1940s, 50s, and 60s, there was no vitrectomy. This is all they had. So they had to try to figure out what works best in their hands. And they would go to Myra and they would say, can you make this for me? And so then Myra would make it for them, and then they created these standardized nomenclature for the buccal elements, which now all the different companies use. So in this case, you see the breaks superiorly there. And so I put a band around the eye. Now there's different types of band. 41, 42, S4050, 240 is a very thin band that people will often use with an element underneath it. And you have to attach it to the two ends together. Some people will suture the ends together, but I don't like making a break in silicone because it can rip through. If you're using a sponge, you can suture them together if you don't want to use something else to attach the two ends together. But I like using these sleeves. These round silicone sleeves, they fit tightly around the two ends of the band. When they come together, and it just kind of holds it place with friction. And that ends up holding the bands together. And there's different styles as to why people will do different things, but in the end, this patient got an S4050 band, which is a 5 millimeter band, and it's only 1 millimeter in height. But by how you place your sutures, you can have different height to the buccal by what we call imbrication. So you put your sutures 1 millimeter away from the edge of the buccal will end up pushing the whole band 1 millimeter into the eye. If you put them farther away, you'll push it in more. And I advise people to use sutures to imbricate when you're doing a primary buccal because that doesn't strangulate the blood flow into the eye. If you just tighten the band around the eye, it kind of strangulates the blood flow. But if you do a buccal vitrectomy, because you're removing the tension from the inside, you can just tighten the band circumferentially. And this is what people use what we call belt loops for, and we'll show those here in a second. But you can see the band and the cryoscars. And with this S4050 5 millimeter band, it was relatively larger areas, and you can even see infratemporally there's some more lattice, and infranasally as well some more lattice. That's all supported on the band. So this patient will stay good forever, basically.
Did you drain that patient?
I did. I tend to drain patients that are very bullous just to try to get the retina in closer apposition. In that case, I actually did also add a gas bubble because when you drain a lot of fluid, the pressure in the eye drops a lot, and you don't want to develop choroidals. You want your buccal to actually do its job. Now this is another case that's pretty interesting. When I presented this case to retina rounds as to what everybody would do, nobody said they would do what I wanted to do for this patient. This is a 14-year-old girl. She had a detachment that was originally diagnosed 5 years prior, but then the pandemic happened, and social situations happened, and then she couldn't get it taken care of or didn't get it taken care of. And the reason she came to me was because she started developing strabismus. And for a 14-year-old girl, strabismus is very socially awkward for her, so that's what was really bothering them the most. It was not the vision. She was 2300 at this point. You see this big cyst right in the middle of the fovea. There's already foveal atrophy, so you know there's a limitation to what the vision is going to be. And you can see that bright white spot on the OCT on the side. That's a subretinal band. And there's all these chronic subretinal bands here. So many people, in this case, even though she was so young, would do a vitrectomy, and often a buccal vit because the risk for proliferative vitreoretinopathy, or PVR, is very high in this case. But I decided to break the mold and do what literally nobody else said that they should do, and I put a sponge. So the question you have to ask, is it sponge-worthy? That's an old person joke for people who watched Seinfeld back in the day, but in Seinfeld, there were these things called sponges that was used for very limited purposes by Elaine Bennis. And so she had to limit her use of sponges and to see whether or not somebody was sponge-worthy. So in this case, is the eye sponge-worthy? Is the detachment sponge-worthy? There are two typical types of sponges that I use here, the 505 and the 510. 505 is completely round, and the 510 is a hemisphere, right? Half round. I will use them for different purposes, but in this case, I use the 505, and I just put it radially on the one break. So you can see here, this is post-op week 1, after the sponge is on there, and there's the sponge underneath the break supporting the break. There's still a lot of fluid because she has a lot of chronic fluid. I drained a fair amount, but there was a little subretinal hemorrhage when I was draining, so I didn't want that to move into the macula and come out the brake and cause PVR. So I stopped the drainage, I put a gas bubble in the eye, and I told her position face down. And she comes in post-op week 1, vision's improved from count fingers to 2150. Her strabismus is almost resolved, so she's super happy. And it didn't affect her muscles at all because I didn't open the conjunctiva near any muscles at all, because the strabismus surgeons really don't like trying to dissect muscles for strabismus surgery after a buckle. If you do a 360-degree peritome, it ends up causing scarring around the muscles. And so her primary concern was strabismus. It was not detachment. So you have to treat the patient and what the actual problem is. And that's what we did here.
Dude, that's amazing.
And then post-op month 1, she was completely attached. You can see the fovea is completely attached here. And you can see, you know, the imbrication, the support of the brake on the sponge right there. And she's totally attached and her eyes are straight. And so now she doesn't even need strabismus surgery. So that's my strabismus surgery for the day. And this is, all you need to do is find the brake, treat the brake, and close the brake, and then the detachment goes away. And young people have such healthy RPEs that they'll pump out fluid. And I was a little bit concerned about how chronic it was, that the fluid would take a long time to go away. But it went away pretty fast, actually, because she's so young.
It's amazing how quickly young people get, I mean, like by the next day,
Yeah.
like half the fluid is gone, even in a non-drainage procedure. It's incredible. It's like kind of like magical when it works the next day.
And for pneumatics as well. You know, I once had a pneumatic in fellowship, and it was a relatively straightforward 3 o'clock break. It should have been pretty easy for it to do. And she comes in the day after I put the gas bubble and cryo in, and her retina was still detached. So my attending, and it was in the morning, so my attending said, position her in the waiting room, and we'll look at her in the afternoon. So I just laid her down in the waiting room, and by the afternoon, her retina was completely attached. And so then I lasered it, and she totally stayed attached. It's just because she hadn't been positioning. And so if you don't position a gas bubble, it's not going to close. So that's the advantage of the buckle. You don't have to position.
Yeah.
And so that's your advantage.
I have a question for you. So for that radial, how long do you try to make your, I mean, when I do segmentals, I typically do them circumferentially just to cover a larger area, because the idea is I want to support the horns, which is presumably where the traction is. Mm-hmm. But with the radial, you're more likely to catch the posterior lip and allow for greater closure and apposition. What are some tips that you have for people who maybe want to try radials?
So if there's just a single break, you know, I prefer the radial because it doesn't affect the muscles at all, and it doesn't affect the actual astigmatism or refraction of the patient, as long as it's not too anterior. If you make sutures that are too anterior, that can cause astigmatism because you're only contracting one portion of the eye. Mm-hmm. And so what I'll do is I'll put the anterior edge just posterior to the muscle insertions, typically, and I'll bevel it. So it'll be kind of flatter in towards that way, so there's no bulging of the conjunctiva, which can be quite irritating. And then I'll mark the break, and I'll put the posterior edge of the buckle 2 millimeters posterior to the edge of the break. So this way, the posterior edge of the break is well supported and elevated. And I'll show you in a second exactly how I pass the sutures, because that's part of the important part.
To follow up on that, because I think this is important, so you mentioned you put the anterior border of the buckle 2 millimeters posterior to the muscle insertion, and the posterior extent of it, 2 to 3 millimeters back from where you mark. So in this case, what it seems to me is what the clock hour of the break is more important, and you get the elevation from the tightening of the sutures.
Correct. That's 100% correct. Doing a good exam before you start a buckle is very important, and it's really helpful to do that in the clinic so the patient can look where you want them to look and get a good scleral depressed exam, and that'll show you exactly where you need to put stuff. You know, in my fellowship, we were required to draw every buckle we did and draw the breaks, and we would take the drawing and we'd hang it upside down so it's our view through the indirect, so we can see exactly what we were looking at, and we'd attach it to the wall in the room so everybody can see what we're doing and where we're doing and which clock hours we're working. So when you're actually doing the buckle, you're not wasting your time figuring out where things are. And obviously you want to confirm the breaks are where they are, but you should know where to start to begin with. And so that's what I would do. This is a case of somebody who actually had a scleral buckle put on and revised one time, 19-year-old girl. And so she has this fovea off detachment. So this primary buckle failed. And so the the referring retina specialist said, I'm going to do a vitrectomy on this person. So he posted it on the American Retina Forum. And I was like, no, you should revise that buckle some more. And he's like, I've already done it once. I don't think I can do it again. I'm like, send her my way and I'll take care of it. So he sends her to me. And so you can see here that the brakes are not supported by the band and the fovea is off. There's a lot of subretinal fluid inferiorly. So the theory is this is what it looked like before I did the surgery. And this is kind of my terrible drawing, but you can see the band is not supporting the posterior edge of the brake. And there's a band 360 degrees with sutures in place. I think it was a 42 band that was on there. And so I thought, well, what do I need to do? I just need a little bit more support in that one area. And so there are other elements that are not sponges that are actually designed to slip underneath the band. They're called slides, just to give you a little bit extra support. And so you can place a sponge or a slide. There's different places, but if you place this posterior to the posterior extension of the brake, you need suture to add imbrication height to the sponge. You could probably just put it underneath the band, but it's going to slip. And so you want it to hold it in place. And so you can do a vertical mattress suture to prevent migration of the sponge anteriorly and posteriorly, and you can do the horizontal mattress suture to give imbrication over the brake. And that's what I'm doing here in this video. And so you can see this is a bloody mess, right? Whenever you do a revision, there's all this scar tissue you need to clean off, and you want to see what you're doing. So you need to see bare sclera. If you can't see the sclera, you don't know what you're grabbing. So I have a wonderful assistant here helping me out. This was one of my amazing retina fellows, Peter Clark, who's now in practice in Wenatchee, Washington. And so we did this case, and you can see him passing the suture there. And it's not the easiest sutures to pass because, again, there's all this rough scar tissue that the needle is not wanting to go through it. But you can force your way through it. And this is using 5-0 Merceline suture, which gets a little bit sticky, so it takes a little getting used to using. Some people like nylon. I like Merceline because it doesn't poke through the conjunctiva, whereas nylon, you have to remember to rotate your sutures posteriorly. But if you do that, it works as well. And you can see I'm passing a suture posterior to the sponge there to kind of hold the sponge in place in the anterior-posterior direction, as well as having the horizontal sutures around it to give imbrication over the brake. And so when you do this, you have good closure of everything. I only opened the one quadrant. I didn't open 360 degrees. I just opened inferiorly here where the brake was, infratemporally, and that completely ends up covering the brake. And so what ends up happening is that 1 week later, she's completely attached, fovea attached. She's actually 20/20, didn't change her refraction, so her glasses still work for her, the ones that she had from before. And she's very happy. I actually just saw her a couple months ago, and she's doing great.
Dude, what a time to be alive. I think that's amazing. I am always scared of doing buccal revisions because it ends up being a bloody mess. Mm-hmm. So I love what you said about the Merceline, because I actually use nylon because I think one thing that I've learned doing buckles is you're much more likely to get anterior migration and slippage over time if you don't have a solid at least 50% thickness. And I struggle, I'm not, whenever I've used Merceline, assessing depth. I mean, of course, you have the needle, but,
right.
I feel that for me at least, it's a little bit easier with the nylon, but super important because, if you actually look underneath the lids and into the fornix, oftentimes you can see sutures that were not rotated, and you have, unless you do a double layer closure, which is why I think that's a really important thing to do, that suture will poke through.
Yeah.
This is a really beautiful result.
Yeah, that was a good point about the double layer closure. Pulling the tenons up helps you with closure for 2 reasons. First, it covers your sutures so they don't poke through. It ends up also making the conjunctiva more relaxed. So when you close the conjunctiva, there's actually no tension on it. So you don't end up getting buttonholes in your conjunctiva. And that ends up making the conjunctiva more usable if you need to go back again. It's easier to dissect again. Hopefully you don't have to, and certainly not a third time in a case like this. If this one had failed, I would have done a vitrectomy after 3 buccal attempts. That's 3 times you're out. But it's one of those things where revisions are always a bloody mess. They just are. There's no getting around that. But you just got to take your time and dissect the things you can dissect and try not to cut the muscles, and you'll be pretty good. So this is another case. There's a break here superiorly with this detachment. And in this case, I wanted to do a buccal vitrectomy. And so when you do a buccal vit, I typically will use belt loops to put the band around the eye just to support the vitreous base. But ideally, the band supports the brakes, but it doesn't necessarily have to because you're doing a vitrectomy. But it's better if you can. And so there's these different slides, as I mentioned earlier, different meridional implants that slide underneath the band. And they come with different width and different thickness. And so here's a case that I did. I used belt loops to put the band through. This is a crescent blade, 2.5 millimeter crescent blade. And you can just kind of tunnel through the sclera, half thickness. If the sclera has a decent thickness and doesn't have too thin spots, you can see there's a thin spot there that I avoided for the band. If you can do that, then you can use the belt loops to hold the band in place. But you can see here, this is a 112 element. It's a bit too wide for the space that I wanted it to be in. So I ended up trimming it a little bit. And you can see this is a 25 gauge vitrectomy system. In this case, at first I just put it there to kind of see where it would go. And then I pulled the conjunctiva and chenons up just to see what it looked like. And you can see the band there is, the slide there is just anterior to the break. And so I wanted to revise that so I could actually get better coverage. So I ended up taking it and just sliding it down a little bit there. And just as long as it's underneath the band, it's not going to slip posteriorly behind the eye. And so once you have it there, now you have good imbrication over the break, and so now the break is completely covered. It's an inferior break, and I didn't want to put oil in this patient. And so you're able to do this and get support, and that completely covers your breaks, unless you're retina to be attached.
That's a really, I love the electric slide technique. And one thing that I've noticed is, you cut these elements. You don't have to put any sutures. Is that true?
Correct.
It's just the belt that holds it tight.
Correct.
And I think that's a really good point. Especially for people who are thinking of stocking their ASCs and trying to get these things, all you need is one of those. All you need is a 112 because you can cut it and make it smaller.
Right.
You made a great point about scleral thinning. I think, one of these, when we do our dictations, all the oblique quadrants were inspected for scleral thinning or dehiscences. It's super important because, you can sort of plan in certain areas to go more anterior, more posterior. I've had situations where I was anterior to the area of thinning, and when I tightened my suture, it popped a buttonhole through the sclera.
Yeah.
And it was a buccal vitrectomy, so I could hear air when I did the air fluid exchange, and I was like, oh my God, now I have a ruptured globe. And I had to close. Thankfully they're attached,
Yeah.
That's all that matters. But I think that's a really unique technique. So you went over encircling bands. Mm-hmm. You went over sponges, and you doing them radially, which I'm looking forward to try, because all that matters is the clock hour, as long as you're consistent with the positioning 2 millimeters posterior to the limbus and 2 millimeters posterior to the marked break. And you talked about the slides. I think these are amazing tips especially for young surgeons, fellows, young attendings that want to get better at buckles. So I wanted to share some of my cases and get your opinions. And I show here some of the things that I did. So I did a lot of encircling bands in fellowship. And one thing that I think is an early sort of gateway into doing more buckles is adding one of these tires. So this is a case, 25-year-old chronic RD. You can see these gigantic retinal cysts. The macula is off. The vision's about 20/80. How would you approach this case? This is a hyaloid on very young patient, student concerned, about getting back to school.
So in a case like this, like you mentioned, there's these giant retinal cysts, which is something to worry about. They will flatten once the retina is attached, but it can cause weird vectors when you're actually trying to close the break. And because of the age, you definitely want to do a buckle, and 6 o'clock breaks, you definitely want to do a buckle in this case. Because the area is so large, I would put a big element in this area. So I would do a 240 band for 360 degrees, and for the inferior, probably 120 degrees, I would put a big element like a 276 or a 287 to support these breaks and the cysts at the same time.
And that's exactly what I did. I learned that from you. I remember posting this case in the Retina Forum, and I actually ended up doing a 41 because I like a slightly wider band with a 287 wide groove. This is the day after surgery, okay? You can see here that extra posterior kick that you get from the 287 wide groove. You can see exactly where I started and finished it. I slid it right underneath the inferior rectus, and the retina is already reattaching. I actually did drain in this case, and I do a needle drainage. And one thing that I've noticed is with chronic fluid, all I do is at the anterior border of the 41 band, I stick a 27 gauge guarded needle in, showing about 2 millimeters. I have the sleeve, piece of the sleeve guarding it. And even if you don't get a lot of drainage, once you tighten the buckle, there's a hole there, so you get some passive drainage. And after that drain is when I added this element, which I thought was helpful. A week later, the cysts are gone. I saw this and I'm like, buckles are magic. What a time to be alive. The retina is completely reattached, and you can see the nice cryopexy reaction. So I'm thankful for all the feedback on the American Retina Forum, and this patient's doing very well. This is another case. Similarly, we'll fly through this one because the approach is very similar. You see here, this is a right eye of a 40-year-old guy who has lattice 360. This is a nice steered view inferiorly where you can see the 360 lattice and the holes infratemporally. I did a similar thing here, basically similar approach. Macula's off. I did a 287 wide groove with a 41 band. You see here, all I treated was I did not treat the lattice areas. This is something that, I'd love your input on. I think that all you need to treat are the open breaks. So in this case, I added the 287 wide groove with the temporal view here. You see where I started and ended the extent of the 287 wide groove. I just did cryo to the causative holes. And my opinion, honestly, is that you've supported those other areas with the encircling band, so I don't treat those areas. What are your thoughts on that?
That's totally reasonable, because you don't even have to treat the breaks at all if you close it forever with a buckle. I did have one attending, Vincent Rapucci, in New York, who would sometimes not even put Pexi during the case. He would just put a sponge. He knew where the break was. He'd put the sponge over the break, close the break, and I saw him do buckles in like a fourth of the time that it would take me to do a buckle when I was faster. It was impressive. And if the patient ever wanted it removed, he would just laser it later on when the retina is attached, and then he'd say, I'll remove the buckle in 3 months. And his success rate is incredibly high. And when people like that are just so used to doing buckles because they trained and that's all they did was buckles, they just get so good. In a case like this, I probably would not have put an element on. I probably would have just put a 42 band, which is a slightly larger version of the 41 band, or an S4050 with a little bit wider coverage for 360 degrees. And I would have cryoed these areas that are broken for sure, and I would have lasered any areas of the attached lattice, but not the detached lattice. So I would have started by lasering before I opened the conjunctiva, because sometimes after you open the conjunctiva, the cornea gets a little crappy and your view gets not great. And so I like to do that before I open. And so you do that first. Ideally, you could do that in the clinic, but if you're going to go to the surgery anyway, and I do all of my buckles under general anesthesia, it's just more tolerable for the patient. So I'll laser whatever's attached to begin with, and then I would cryo all of the open breaks. And I don't love cryoing lattice that's not broken, so I probably would wait to laser that later in clinic.
Got it. Yeah, no, it just goes to show there's so many different ways to approach detachments. And you showed us that chart with all those different types of buckles. There's a lot of different ways to reattach these retinas. So, another thing, so the thing with buckles is that you need confidence that it'll work. So this is a pseudophakic patient with a very large infranasal break. And one way to get comfortable with non-encircling bands, a lot of fellows are doing encircling bands, and that's not necessarily, it doesn't allow people to have confidence that, okay, we're gonna just fix this with a buckle. So if you're doing a buckle vitrectomy, if you have a few causative breaks, a good thing to do is a vitrectomy with a segmental scleral buckle. And I've had some good success with doing that and increased my confidence in the fact that, all right, I can reattach this with just a buckle. So these large breaks, pseudophakic patient, I'm going to do a vitrectomy here. It's more inferior. This is not a pneumatic candidate for me. So in this case, I ended up doing a segmental buckle with a C3F8 gas bubble. And you see there's beautiful imbrication. I was so happy with this buckle. But unfortunately, because I only covered the infratemporal aspect of it, you can see that there's worsening detachment further inferiorly and inferonasally. So in this case, I went back in and I was like, all right, I'm sorry, sir, we're gonna have to go back in. I may need to add more of a buckle element. and I ended up adding another segmental. So this is not standard, right? This eye is now under oil because I was concerned because I couldn't find a break anywhere else and there was no real PVR. And I maybe have less patience. I was like, I can't dissect anymore. I tried for like 20 minutes trying to dissect the conjunctiva. It was a bloody mess. I didn't have a skilled assistant. I was like, you know what? We're popping another segmental on there. So there's a nasal segmental. I had the extent a little bit higher and I did oil in this case. You know, the reason I'm showing this is just to show that it's modular. Buckles are modular. You can, you know, could I have added another encircling band? Sure, if I was a more patient surgeon and wanted to do that. Thankfully, this patient's doing well, no PVR. And then finally, now I've had my gateway. Now I've proven to myself that I can reattach the retina with just a buckle. So this is a young 45-year-old guy with a chronic break that I tried to laser in clinic infratemporally in this left eye. And the fluid is starting to get worse. So what would you do in this case?
So it's a relatively big break, and it's just slightly posterior to the equator here. So, you know, 45 years old, I would still do a buckle, but in this case, I'm a little wary about what's going on the nasal side as well. So I would do an encircling band here. If I needed to put more elements in to kind of support, I would do that. I'm not sure that I would do a sponge for a case like this just because of the size of the break there.
Yeah, no, I mean, I think an encircling band is very reasonable surgery. The reason I opted against it is because they had a gigantic pterygium, and I mean, dissecting those things kills my vibe, you know what I mean? So I don't want my vibe killed in the OR. So I actually ended up doing a circumferential segmental. And I ended up here using a 510, which is flat on the top. I like the flat elements on the top. And you know, remember, for all our younger attendings and fellows, it's helpful to pre-place these sutures, and then you slide it underneath. And what I find really helpful is when you're tightening it, you do your 3, and then you tighten. And then I have the assistant take a Nugent forceps and push on the eye and say, I want you to push there. And then you tighten a little bit more. And then you lift up on your suture, you tighten a little bit more. And that's how you get the imbrication. Remember, it's curved at the bottom half. And I think that's one thing to remember. When we think about encircling elements, they're flat and they get less imbrication. But with this flat top, you're literally pushing a curved surface onto the eye. So I ended up doing a segmental, which is nice because I only had to dissect about 5 clock hours away from the pterygium in this case. And the patient actually did quite well. It ended up being a bit more posterior than I was expecting. And why do you think it ended up being a bit more posterior? Thankfully, this patient is nicely attached. You can see the cryo reaction on the brakes here, but it's a lot more posterior than I expected.
So I actually think this is a perfect placement. I would put it exactly where you did put it.
Thank you.
And so like this is perfectly done. There's nothing wrong with this case. It's like there's no points you can add to make this better. This is absolutely perfect surgery. But the reason it's more posterior than you thought it was possibly was because if you go back to the pre-op photo, I'll show you where the break is. The break is relatively, it's got a fair amount of fluid underneath it, and so the break is actually more anterior than you think it is by where you look at it is. When you look at what the blood vessels are, because of the way the optos works, or even with your indirect, things that are attached will look farther away than they actually are. And so what's going to happen is that the break is actually more anterior than you think it is. And so even when you examine the patient in the OR and you mark the break, your break is actually going to be about 0.5 millimeter to 1 millimeter more anterior than your mark in a case like this. If it's very bullous, it could be in a completely different location. And so these are things to know, and reasons that you're doing the wider encircling, or in this case segmental circumferential support here. Why a sponge and not like a 287 or 276 in that quadrant?
I wanted to get better at these. I just wanted to try something different, and I wanted to gain confidence in imbrication. And after talking to you today, I think I could have covered this with a radial element as well, but what I would be concerned about is how far posterior to go, because I think that's the only break. It's just 1 clock hour, and also it's less dissection. Another important point to remember is, if you can literally dissect 1 quadrant, and there's some great videos on how to hook the muscles, without necessarily dissecting in that area, and then still and you're still getting the rotation. I think that's really important to get exposure, especially if you want to put in sutures or put in belt loops more posteriorly.
So in these cases, I'll actually just put a traction suture at the limbus, like glaucoma surgery, like AAO vicryl that I'm going to use to close the conch later. And I'll just pass the suture through the limbus and I'll tape it to the drape, and then that'll get me my exposure. And then you don't need to even touch the muscles.
Yeah.
And so if I could avoid touching the muscles, that's the reason why I want to do these segmentals and these sponges in the quadrants, because then I don't have to even dissect the muscles. And then that doesn't cause strabismus later on. It doesn't cause scarring. If you need to go back in, it's easier to dissect now because you haven't created a capsule around the muscles. And so in those cases, I don't open the muscles at all.
That's a really great thing. The corneal traction sutures. That's definitely one thing I want to try, because then in case you do have to come back and revise, you're dealing with less scarring, and that capsule can be a bloody mess. So we'll go to one last case here. So this is a young lady, 30, mid-30s, who has atrophic holes and supratemporally and lattice inferiorly. There's an area of detachment. The patient is symptomatic. How would you fix this? This patient also has some inferior lattice.
So I would laser the inferior lattice, and I would do a pneumatic in this case. Like it's just the location of the brakes are superior, and your pneumatic, if you put a big enough buckle, they won't even have to position that much. It'll just be kind of natural. And the goal is to make sure that the lattice laser in the attached area scars before the fluid gets pushed posteriorly or inferiorly in this case. So I would laser the lattice because it's a MAC-on detachment. You have to take care of it today. And the advantage of the pneumatic is that you keep the fovea on now. So this is one case where I actually would not have buckled this. I would have done pneumatic.
So interesting story here. I did exactly what you did with the lattice inferiorly. I lasered the lattice inferiorly, and I wanted to treat this with a scleral buckle. So again, because I'm still too much of a coward to do a radial, which will hopefully change after today. So I did a segmental circumferential, similar 510, 511 element here. I think this is a 510. And you see here, a week after surgery, there's nice imbrication. It's a bit more temporal than I want it to be, and there's an uncovered break superiorly. It's covered, but it's not adequately supported. And we said, all right, you know what? Let's let the scar in. Let's see what happens. Let's let the buckle work. Let's let the change in the fluid dynamics in the eye work. And we waited another few months. And you see here, there's nice scarring. But if you look closely, there's still fluid there, and the fluid over time started to progress. So now I did exactly what you did. I was like, all right, you know what? Time to do a pneumatic. So I did a pneumatic. I did an SF6, a pretty big SF6 bubble. This is about 4 days after. You can see the laser mark superiorly. And what you mentioned about the shifted fluid, you can see supratemporally here and supranasally there's some shifted fluid. Thankfully, there are no breaks there. I was concerned, whenever there's shifted fluid, you wonder, is it because, is there a new break, or is this shifted chronic fluid? Thankfully, in this case, it was shifted chronic fluid. The bubble's slowly going away. And you see here the retina's thankfully nicely attached, and I can sleep better at night.
Beautiful case.
Yeah, no, I mean, it just goes to show, there's so many different things you could do with buckles. And honestly, like every time I have a retinal detachment now, talking to, people who've done a lot of buckles like you and others on the Retina Forum, I've gotten more confident at it, and I'm really thankful for that. So thank you for creating this great platform for us. And I actually get excited when it's like, you know what, let me see if I can buckle this,
Yeah.
And it really is, and I hope that the next generation of retina specialists don't lose this art, because it's such a beautiful way to fix the retina. The elegance of it is just amazing.
Yeah, it's something that definitely should not go away. It's a skill. Everyone needs to have all the tools they can and be as comfortable as possible with all the tools that are available to us. And if you're a little intimidated, or maybe your ASC doesn't have the buckle elements, just start with a few of them. Like if you want to just start with a 41 band and get wide groove elements, and maybe have a slide or a sponge or two, just pick one and stick with that one. And if you pick one that does most of what you need to do, that'll solve your problem more than 90% of the time. So most people will do a 41 band with a 287 wide groove because they don't make a 276 wide groove. And so those two, and that covers you almost always. If you want to add slides like a 112 afterwards, you can. If you want to add sponges, you can. In this case, I will typically use the 505, but some people like the 506, which is an oval-shaped sponge that's 6 millimeters in width, and it works really well. And so these different ones that people use, after a while you can get fancy if you want to start having more toys to play with, which is kind of fun because there's an art to buckles, which is really nice. And I want to give a quick shout out to Hamang Pandya, who actually was the one the original idea for the Young Retina Forum back in the day, back when he was a fellow. There was no senior fellow in Oklahoma when he was in fellowship. And so he didn't always have a good way of asking quote unquote stupid questions. And he didn't want to look foolish in front of his attendings in this place. So he would text us and ask us. And eventually we did it all on WhatsApp, so it was encrypted. And so he would ask a few of us, and slowly it went from just him doing individual text to people. So then he created the Young Retina Forum kind of as a joke. And there were 5 of us on that chat. And then someone would ask a question and we would say, oh, I remember I was talking to this guy about that. And this person posted something on Twitter about that. And so we added them to the chat, and it went from the 5 of us to now it's over 500 of us. And we're all learning together. You know, I've been in practice for over 10 years now, and I still learn stuff every single day on the chat, which is pretty impressive.
Yeah, it's amazing. The community that we have to learn from each other allows us to constantly get better. And, you know, it's really great to have that kind of platform. And, you know, that's what's motivated us to create RetFix and Chill, because this is another way for us to share knowledge and constantly keep getting better. Dr. Mehta, thank you for joining us. Another great episode of RetFix and Chill. Thank you, everybody, for joining us. And we're signing out from Chicago.
Bye, everybody.